all these little post-its around because I forget to hit record, and then you wind up with the morning lecture in yours. But I hit record this time, so it's all good. Awesome. Well, welcome to week 2 officially. Just crazy. It's already the second week in, so we got one done, and that's 1 week closer you are to graduating. So that's the key. Eye on the prize there. A couple of housekeeping things we'll start off with, if there's not any questions, is one, thank you for the assignments this week. If you haven't had a chance to do the assignment, please do it and submit it. Any points count. Trust me on that. All the way at the end, you're going to wish that you got them in. As you realize, those of you who put in your assignment, I've already graded them. They're in there. Everyone that I've got has been graded. If you jumped ahead to other assignments like next week, it's already graded. If you've got your 2 replies in your initial post, it's already graded. If you jumped ahead of that, for your pamphlet, it's already graded. So I try to keep well on top of your grading system. One thing I found infuriating as a student is when teachers did not post the grades and I didn't know where I stand. So you don't have to worry about that with me. One thing I wanted to clear up on this assignment, granted, I'm not a big, APA is something I'll look at. However, I'm not going to dig for points off. But I want to make a clarification because I saw it in more than one assignment. Note when you're doing an in-text citation that in APA format, the in-text citation should be parentheses, author's last name or authors, multiple, comma, the year of publication, and parentheses. MA format is where you have a number. So in the references in APA format, you should not have a number. You should not use a number for citation. It's just the author's last name, comma, and the date that it was publicized. I did not take off any points for that, nor will I. I find that as an opportunity for education, so that's cool. A couple of housekeeping things. So we got the assignment done. Please submit that. Your discussion post is this week. A lot of you have gotten on top of that already. A surprisingly large amount of you have gotten on that. Just remember, it's 1 initial post and 2 replies. I like the discussions. I look for professionalism. I look for civility, which we spoke about, and that you kind of got things evidence-based and cited. If you disagree with someone, that's okay. That's the way it's supposed to be. Yes, Yanine, no problem. You didn't mean to yell at me in that chat with all your caps, so I got it. Other than that, welcome to everyone. I see some new faces, some old faces, and a lot of just names on black, and that's okay. I will be shutting my camera off for the lecture. The other thing I want to clear up, which I don't know if this group has noticed yet, but in week 9, you have this mandatory NCLEX review. Does that sound about familiar? It's a 3-day course. It's the 31st, 1st, and 2nd of June. Yeah. So this ruffled a little bit of feathers because what is week 9 for us? It's our exam, and our exam is supposed to be on campus. Absolutely. So that made it a little bit of a conflict. So I've been going back and forth with the deans. Dean Pacheco does all of the scheduling for in-house. The problem lies is this is an on-campus test, and you have that same day there. So and 1 o'clock isn't going to work because that's the time you normally take is 1:30. So the only thing we've come up right now, and it's tentative, it's still week 9, but what we have right now is that everybody on the Tuesday group, the morning class and the afternoon class, are going to come in and test at 7 a.m. This is what the deans have come up with, and it seems to be the only viable option. We can look at other days. The problem is not everybody has the same schedule. So some people have a day like Friday, but other people have a clinical that day or a simulation or something. So tentatively right now, plan on a 7 a.m. week 9 on campus for the exam to open up and take that before the NCLEX review. The NCLEX review is a third party, so that's not run by Rasmussen. We don't have any authority to move those days around. So just don't kill the messenger, but I am working with them to try to find a viable option. That seems to be right now the most viable option. So if anything changes, and as we know, the only constant in nursing school is fluidity and change, so it will post the info for the NCLEX review. I don't have the info for the NCLEX review. I believe that's Teresa O'Neill has that. I would reach out to her. I don't even have, I just have what she told me, but I'd rather it come from her than from a secondhand source, which would be mine coming from her, hoping I got the details right. I do know that it is 3 full days. It is not just one of the 3 days. So that was clarified for me. There seemed to have been some confusion around that. Okay, comp predictor. All right, any questions on that? Okay, yeah, so anyone who's just added to her class, just double check on that. I'm gonna share my screen really quick. Screen 2, share. Everyone should be able to see that. Yeah, it looks about right. You see me looking over to the left like this, I'm not having a stroke. It might be, I don't know. But I have another monitor over here. It just makes things a lot easier for me to see. So can everybody see the course shell? Looks like Blackboard. Yeah, perfect. All right. So this is just your discussion this week. It's pretty cool. So you're on a neuro unit, and preceptor informs you to be prepared to discuss the following topics. They're commonly seen in the unit. So in order to prepare, you choose one, just one of them, and post your initial post discussing, here we go. One, either how do you assess a client when the nurse suspects an onset of a CVA, and we're going to go over that today. Provide discharge instructions, information for a client with a mild traumatic brain injury, discuss surgical management of brain tumors, and describe postoperative complications of a craniotomy. Any one of those, 1, 2, 3, or 4. You don't have to do all of them, but your initial post. Make sure that you have your evidence base in one article that supports your response, and you have to have 2 replies with that. So one initial post and 2 replies. Initial posts due this tomorrow, and then the replies by the end of the week. So take your time with it. Like I said, a lot of you already jumped on that. Any questions with this week's post and discussion assignment? If you do throughout, just shoot me an email. It's not a big deal, and we'll go on from there. And as Billy Squire had alluded to in the, in the song this week, we're talking about strokes. Do we come on campus for the ATI? No, the ATIs are still online unless something changes, which I would find hard to believe that it would change from this point on just because of the vast amount of people on campus and the limitation of rooms. So right now, ATIs are online as they would be. They'll be at your class time. Your ATIs are week 4 and week 8. They will start at 1 o'clock, both days online. You will not have class that day. There's a recorded lecture that'll be uploaded for you. All right, can everyone see my PowerPoint? Yep, awesome. Okay, I'm going to shut my camera off because you don't want to see it, my ugly face, but you get to listen to my irritating voice. So, yay. Win-win. Winner, winner, chicken dinner. All right, well, this whole week, Module 2 is a lot more digestible than last week. Last week had a lot of obscure neuro. It was heavy neuro. And this is more familiar neuro. So that's what I like about this. We have some stories I can tell you that can help tie it in. I have lots of videos in this that help kind of show and bring it in, and we'll just kind of talk about it. So the first thing we're going to start about is the epidemiologic factors of cardiovascular accidents or strokes, cerebrovascular accidents. So epidemiologically, every 40 seconds someone has a stroke. And that's crazy to me when you think about it. Every 40 seconds someone has a stroke. So it's prevalent. It's profoundly prevalent. And you will undoubtedly in your nursing career take care of a acute or a long-term stroke patient. It's the 3rd leading cause of death in the United States. So one of the things some people are, I'm going to say, lucky enough to have is a thing called a transient ischemic attack. And a transient ischemic attack, or a TIA as they're affectionately known, is this temporary neurologic dysfunction resulting from a very brief interruption in cerebral blood flow. It usually resolves within 30 to 60 minutes, sometimes up to 24 hours, but the key word in that is resolves. They have symptoms, and those symptoms return back to baseline. So it's really, really high indicator of the high probability of having a stroke. Multiple TIAs, however, if they keep going unrecognized or untreated or trying to get the etiologic factors, is that can damage brain tissue when you have multiples. So when we look at a TIA and we assess patients with a TIA, we assess them by their systems. Again, that temporary neurologic dysfunction, and the time frame vacillates from patient to patient, but they always return back to baseline. They may have some visual deficits. That could be something as simple as blurred vision to double vision to complete blindness in one eye or tunnel vision. Mobility deficits, again, the hallmark of cerebrovascular accidents and a lot of transient ischemic attacks are those hallmark symptoms. Facial droop on one side, arm or leg drift, hand grasp weakness, dysarthria, ataxia, unsteady gait. They have sensory and perception deficits most of the time. Numbness, usually to the affected side, face, hand, arm, leg. They may have some vertigo that's accompanying with it. And usually speech deficits. That's aphasia, or more importantly, it's a dysarthria. No problem, Wendy. So when we intervene with TIAs, we kind of want to look at the underlying cause. Because remember, to me, at TIAs, nature's a little wake-up call saying, hey, something's going on. You probably want to get it taken care of. And down below here, you see this stroke, this FAST. You'll see this in the hospitals. Those of you who currently work in the hospitals or have clinicals, you probably see this peppered about a hospital. facial unevenness or asymmetry, arm or leg drift, wandering, speech, slurred speech, speech deficits, and it's a time to call 911. So again, the TIA is just a warning sign of a possible stroke. It's our time to educate the clients, and that's what nurses do really, really well, is educate. So first, reduce high blood pressure. If they're on medications, be adherent and compliant to that medical regimen. Take aspirin or other antiplatelet drugs if they've been prescribed. We don't want to just tell them arbitrarily, just take some aspirin. No, it goes to their provider. And these antiplatelet drugs are awesome because they help reduce the chance of that initial clot formation. We want them to control their diabetes. We know that diabetes wreaks havoc on the vascular system. And also promote that healthy lifestyle. And those lifestyle changes, that's smoking cessation, exercise, diets. So when we look at that FAST algorithm down below, again, 911 pre-hospitally, but what if we're in the hospital? So you're taking care of Miss Jones in 202 bed 2, and you go in there and she's dysarthritic with left-sided hemiplegia and facial droop and arm drift. Who's the 911 of the hospital? Who do we call then? Rapid response. Yeah, absolutely. Rapid response, stroke alert, whatever that hospital is calling, you want to get help there quick. And there's some things we can do in the interim while we're waiting for them. We'll get into that a little bit later. So, quick question. A TIA typically lasts 24 to 48 hours, is a result of a previous stroke, can be a precursor to a stroke, or can result in permanent deficits. What do you think? 1, 2, 3, or 4? What is a TIA? 3, 3, 3. Yep, you got it. It's definitely a precursor to a stroke. Strong work. Now, if you're not lucky enough to have TIAs, or you've had multiple TIAs and you've kind of ignored them, it may reach to the level where you have a CVA, a cerebral vascular accident, or a stroke is what it's most commonly known as. And this is a complete interruption of perfusion to parts of the brain, and it results in death of cerebral tissue. They have cerebral infarction going on. That blood flow is affected, causing damage to other parts of the brain, which causes increase intracranial pressures and causes other problems. We learned last week that increase intracranial pressures is not a great thing. So we also have to understand there are different types of strokes that are out there. We can have an ischemic stroke, and that's most of them. 87% of all strokes are ischemic in nature, and it's caused by either a thrombus or an emboli. And we know that a thrombus is a blood clot, but what's an emboli? What kind of emboli can there be for a patient? Anyone know? Pulmonary? Yeah, but what can be the causative? What are the causes? What types of embolus are there? Air. Excellent, Courtney. What else? What about fat emboli? Where are those from?
Yeah, I was going to say fat.
Perfect. Fat emboli. What about us? What about nurses? Can we cause emboli? Physicians? The oopsie whoopsies of the world? Yeah, DVT, that's a type of emboli, yeah. Yeah, we can. What if I'm a nurse and I'm there and I'm putting in an IV? Yeah, an air embolism is one of them. And I don't think it's in, so I'm going to pull that catheter back. I'm going to push it forward. I'm going to pull it back, and oops, my sharp tip of the needle sheared off the end of that catheter. Ugh, sorry. So again, that can be cause of an embolism. We can cause that. And the last one, you probably learned about it in mother-baby. Anyone know what that kind of emboli is? Usually postpartum. Yeah, placental fragments. Yeah, it's called an amniotic emboli. Does that ring a bell to you? So yeah, from the placenta. And amniotic embolisms are horrific. They usually cause pulmonary emboli, again, on that side. But yeah, there's different type of emboli. So again, usually it's a blood clot, but it can also be from something else in the body. Is anyone familiar with the left atrial appendages? Has anyone not heard of the left atrial appendage in anatomy and physiology? It's surprising, a lot of people haven't heard about it. It's a very, very important structure, particularly when we talk about ischemic strokes. We're going to go over a brief slide on the left atrial appendage, and it's something that I think most people are overlooked. But to get into that, strokes often result from heart disease, so atrial fibrillation plays a big role. We spoke about that when we talked about kind of the next level questions, MDC4 questions. You know, someone's getting an echo that came in with ischemic stroke. Well, we need to know that atrial fibrillation, they have a high likelihood of having a stroke if they're under anticoagulated if they haven't been anticoagulated, and also postoperatively for heart surgery. Hemorrhagic is the other type of stroke. So ischemic is one, hemorrhagic is the other, and if we pick that word apart, hemorrhage is in there. Hemorrhage means bleeding, and that could be a subarachnoid hemorrhage, or it could be an intracerebral hemorrhage. So let's talk about that left atrial appendage for a second. So if we look at this kind of dissection of a heart here, this is the left atria. But off the left atria is this tiny little thing. It's no bigger than the tip of your pinky. When I was doing cadaver labs, I'd always cut open the heart and I would have people actually put their pinky into it. It's remarkably thin-walled and it comes right off that left atria. What's most important about this left atrial appendage is it doesn't really do anything throughout your body. So normal cardiac cycle, the atria contract, this contracts a bit too, blood forces out, it goes down. In atrial fibrillation, however, those atria don't contract, do they? You lose that thing called atrial kick. They just sit there and fibrillate. They just kind of are like little worm-like structures. But in diastole, as the ventricles relax, a big vacuum happens. So most of this blood is just pulled right down in the ventricle. About 30% of it stays in there because you lose the atrial kick. However, this doesn't contract. And this is a large area of stagnation. So blood just kind of pools in this left atrial appendage. 99% or more of blood clots from atrial fibrillation form the left atrial appendage. So it becomes a very important structure. Morphologically, it's broken down into different shapes, and they're funny shapes. One of them is called a windsock, and it looks just like a windsock, like you would see at any airfield to indicate wind, direction, and velocity. But there's other shapes. So these two, cactus and cauliflower, usually are combined to form one that's called a broccoli. Kind of, you can see how broccoli shape is out of both of those. And then there's a chicken wing, and it's where that windsock kind of takes a turn. It can be multilobar. But the thing about that is if blood clots form in these, we wish there was a way that we can prevent those blood clots from forming. Here's an echocardiogram, a transesophageal echo that you can see. This is called a mural thrombus. This is a thrombus that's attached to that left atrial appendage. You can see it in different views there, and it hasn't migrated yet. But if this breaks free, where do you think it's going to go? Right to the brain. This is going to cause a significant stroke, judging by the size of that clot. So luckily, our technology is advanced where not only do we recognize that the left atrial appendage plays a significant role in clot formation with atrial fibrillation, but we have a way to help it and actually seal it off. I'm going to show you a video here about a thing called a Watchman, or it's a left atrial appendage closure device. It's pretty remarkable. It's done in a cath lab. It takes about 45 minutes to do for a patient, and it changes their life forever. Because after they put this device in, they can come off of Coumadin completely, or warfarin, or whatever blood thinner, which is a significant life changer.
We appreciate your interest in considering the Watchman device for the treatment of atrial fibrillation in patients that aren't able to take anticoagulants. If you qualify for this procedure, this is a procedure that is done within the hospital. You will undergo general anesthetic. We will then seek to get access in the right femoral vein, take a catheter up into the venous system, and go up just past the heart, at which point we will get our equipment ready in our attempt to get into the left side of the heart. The appendage, which is the area of our concern and the area we want to obliterate, is on the left side of the heart, and so we'll need to cross over into the left side of the heart. We do this with what's called a transeptal catheter. The catheter will help us locate a spot where the tissue is relatively thin between the right and left part of the heart. We'll then cross the septum with a needle and then pass our catheter into the left side of the heart. At this point, we push the catheter and our wire into what's called the pulmonary vein, which is a good landing zone for this relatively large catheter. As you can see, the appendage lies below the pulmonary vein. There are different types of appendages, which is apparent and is very important to us as we attempt to determine what size device to use. At this point, we replace the catheter with what's called a pigtail catheter, and we navigate ourselves into the appendage, at which time we make appropriate pictures to determine the size of the appendage as well as the shape. At the same time, our colleagues who do the imaging with the transesophageal echo are confirming the same things in regards to size and shape. As you can see, the catheter is marked and helps us determine the size of the device we need. At this point, we take a confirmatory picture of the appendage with contrast dye and then pick out the right size device to use. The device is then loaded through the leg, through the catheter, up into the appendage. At all times, the device is tethered so that if we have any difficulty with the location, we can pull the device out. The device is then placed deep into the appendage, and as it's slowly removed, it opens up. The device is made of nitinol and has a PTFE covering that initially is permeable and allows blood to flow back and forth. Over a period of about 30 days, the device gets tissue over it, and now no longer will allow blood flow from the appendage back into the left atrium, and hopefully therefore prevents clots from going back into the central system. As mentioned, the device is tethered the entire time. If we feel comfortable with the position, there's no leaks, and it's well positioned, we release it. At this point, the patient's able to go home the following day. They are on Coumadin for approximately 30 to 45 days. At this point, we get an echo, and if the device looks good, they just go down to a baby aspirin and Plavix per day for a total of 6 months, and then just down to a baby aspirin. We appreciate your interest.
So it's amazing, that technology, because it's absolutely life-changing for the patients who have chronic atrial fibrillation. Again, it's limiting. They're on these blood thinners. They really can't do a lot that really predisposes them to bleeding problems. So that Watchman procedure, and that's a proprietary name, it's a left atrial appendage closure device, is absolutely life-changing. I was fortunate enough to start that program at Brandon Regional in their cath lab with Dr. Gouda, and amazing. I think there are over 100 or more than that of those Watchmans put in. Those patients, their life opens up. They can go back and live relatively risk-free from bleeding. So it's amazing what technology can do. The other thing we talk about are those types of hemorrhagic strokes. So there's intracerebral, so it's bleeding actually inside the brain tissue itself. Underlying causes of that can be severe or sustained hypertension. Some drugs like cocaine cause underlying and exacerbations of hypertension. It does lead to brain damage. That bleeding is very caustic. Blood itself, it causes edema, it causes irritation, but more importantly, it's space occupying. And if you look at that cranial vault and recall a thing called the Monroe-Keeley doctrine, it just says that there's enough space for brain tissue, cerebral spinal fluid, some blood, but not much else in the meninges. So when you add volume inside that cranial vault, the skull's not going anywhere, so something has to give. And brain tissue is usually the most pliable and the most easy to displace. So it winds up doing a thing called herniating, moving either one side to another. So in this picture here, this would be the midline. You see how that wavers off the midline? That's called an uncal herniation. This is a subdural hematoma. Subdurals look like bananas under a CAT scan. Or the opposite is if it's all encompassing and it starts pushing the entire brain, it can do a transtentorial herniation where the whole brain stem herniates through that foramen magnum, that hole in the bottom of the skull. We also have subarachnoid hemorrhages. These are much more common. This is a ruptured aneurysm or atriovenous malformation and AV malformation. And upper right here, you can see what an AVM is. Normally at this capillary interchange between the arterial system and the venous system, it's very low pressure, so it's able to travel and traverse that very easily. With a malformation, it becomes very convoluted, and there's engorgement of the arterial side, which in turn engorges the venous side. And the venous side has very, very thin walls, so they get very dilated, and then it runs a risk of hemorrhaging and bleeding. So it's classic symptomatology for a subarachnoid hemorrhage. The patients come in, they have this acute onset of this sudden severe headache, and they usually say these words: "I'm having the worst headache of my life." Or, quite often we ask that, is this the worst headache of your life? Absolutely. I was working in a hospital emergency department in Las Vegas, Nevada, Sunrise Hospital. I was working triage that day, busy, and this younger, late 20s person comes up and says, "I had the worst headache of my life. It just came out all of a sudden." And those little red flags popped right up. Got that person triaged to the head of the line, went back, and lo and behold, had a whopping subarachnoid hemorrhage, which we were able to actually intervene early on for that patient. But that's the pretty classic symptomatology. They may or may not have impairment of consciousness. That's the thing. The problem with bleeding is a normal physiologic response to bleeding is vasospasm. Your body says, okay, it's a bleeding cascade. Let me first and foremost shut down all the vascular system. Well, it's great for the bleeding, but it's problematic because it's not isolatory to one vessel. It's usually a group of vessels. So now we get secondary focal brain ischemia to other areas of the brain. We can get meningicisms, which is meningitis type things, hydrocephalus, which is enlargement and persistent headache of the whole brain. And those are all common symptomatology secondary to vasospasm from a subarachnoid hemorrhage. When we take a step back and we look at that ischemic thrombotic strokes, we know anatomically there's areas of the blood vessels that are more prone to having atherosclerosis, to having potentials for breakdown and clot formation, and those are really in the bifurcating areas. You know, when we look at the circle of Willis here, and this is not an anatomy class, don't worry about memorization of this, but we just know that there's a very large basilar artery that comes up from the bottom, but you also have these branches, these bifurcations. And in normal blood flow, it becomes turbulent there. As the blood is separated, you get these ebbs here, these little arrows, where it just starts to create additional turbulence, a little bit higher pressure. So you add in a little bit of atherosclerosis from poor diets, diabetes, etc., genetics, and again, you get this higher pressures of underlying hypertension. Vessel walls are tissue. So as that blood goes with each heartbeat, as it hits that part of the vessel, it's damaging it, particularly if the blood pressure is higher, particularly if it's more turbulent flow. And the body responds in kind. It increases vascular permeability, it sends its innate immune system in there, white blood cells, macrophages, so it increases and adds to this plaque deposit that's in there. And as it gets larger and larger, and again, the plaques develop between the muscle layers, between that tunica intima layer inside and the tunica medial layer in the middle. And as it gets bigger and bigger in the turbulent blood flow, it sets it up for the possibility of rupture. And as that breaks apart, well, then that sets the whole intrinsic and extrinsic clotting pathways going in there, clot formation, and that's where we get that ischemic stroke from. But we know that they're more susceptible in those bifurcations. This here's a nice form you can have. It's a picture, a table. You can download it. It just kind of shows some of the differential features between a thrombotic, embolic, and hemorrhagic stroke, and kind of represented a TIA, and what you would expect to see in these, and how you can almost clinically differentiate. However, we know that clinically, can we differentiate, or what do you think we would need? What's the magic thing that really helps us differentiate between an ischemic and hemorrhagic stroke? Anybody know? It's that magical test. Any guesses? But diagnostically, can we help differentiate? MRI, yeah, MRI is great, but it takes a while. What's something that's a little quicker than an MRI? Yeah, CAT scan, absolutely. Yeah, CAT scans can go in, they can do what's called a helical CAT scan. They can get them in and out within just a few seconds, and we can see if there's a bleed or not. So great. So here's a quick question. When does a hemorrhagic stroke happen? If blood flow becomes blocked or clotted, if blood becomes too thick to reach the brain, if an artery in the brain leaks blood or ruptures, or when plaque damages the vessel wall. What do you think? 1, 2, 3, or 4? Yep, I've got a couple of threes. Yeah, this is a softball, lobbing that one in there. Again, if there's any rupture, again, it's hemorrhage is in that word, so it's hemorrhagic. So now that we know the epidemiology and the etiology of strokes and the differentiation between different types, what do we see when we clinically assess these patients? Of course, the symptoms are going to vary. It just depends, A, where the clot is or where the bleed is, B, the size of the vessel. So their symptomatology initially can range anything from, slightly slurred speech all the way to complete unconsciousness. When we look at ischemic strokes, they complain of a variety of symptoms, again, depending on the location. The hallmark, weakness, paralysis on one side of the body. Remember, it's the opposite side of the injury. It's a thing called a pyramid decussation, and it happens at the optic chiasm. So the optic chiasm is where those nerves do a 180-degree spin. So what affects the right side of the brain, you clinically see on the left side of the body. But remember, that happens below cranial nerve number 3. So the pupils are actually indicative of the side of the injuries. We'll get into that later. They're going to have, usually dysarthria is the big one. They may have dysphagia, which sets them up for aspiration, poor balance, blurred vision, inability to concentrate, memory deficits, headache, incontinence. Again, it depends on the level. If you did your project on vascular dementia, those are kind of tiny little ischemic strokes, lacunar infarcts that can cause that. On the opposite end is a hemorrhagic stroke. It's usually abrupt, rapid onset, severe headache that they have. Has anybody here clinically seen an evolving stroke happen? I know a lot of you work clinically. So if you haven't had the opportunity to see a stroke, I actually have a video. I think it's important. So the video, although it's it's a fabricated video. It does a phenomenal job at showing a stroke actually evolving, and we'll talk about some of the things with it here.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
Probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911. Honey? Tim! Tim, look at me, Gracie. Tell them to hurry. Tim, look at me. Look at me, Tim. Dad, I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going on, baby? My husband, It's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? I'm right here. Gracie, meet us there. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Huh? Just breathe. Tim?
Dad?
How you feeling? I'm fine. Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
So again, I know that that's dramatization, but it's pretty realistic. Having seen many strokes like that evolve, it's like that. All of a sudden, there's that slurred speech, the inability to move that one side of the body, and, the wife was good to ask, can you lift up your arms? Because what can this be confused with? If you just had this face involvement, what are differential diagnoses of that? If I just have facial asymmetry with some dysarthria, what other things would pop up that can mimic that? Parkinson's? To a degree, but you're going to have full face involvement with Parkinson's. What about a thing called Bell's palsy? Yeah, you got it. Trigeminal neuralgia. Those are the two heavy hitters, and we're going to get into that later. But the difference between Bell's palsy and trigeminal neuralgia is those only affect the face. He has arm involvement. The wife asks him to what? Raise both your arms up. He can't. He can only raise one. So looking at this, they call 911. 911 gets there impressively quick. However, in that time where you call 911 until they get there, what should they do with this guy? What are some of the things they should have done?
Maybe find him more stable seating, considering.
Perfect. Get him to the ground. Lie him down. Put him on his side. He's at risk for falling, and that fall is going to lead to a secondary head injury. So those are basic things we can do. Loosen his clothing. EMS is going to get there. So EMS gets there. What can EMS do from the time that they get there until they get him to the hospital? What interventions do you think they're going to do? Think ABCs. Think along that line. What do you think would be good for this patient? Oxygen? Sure, why not? We'll give him some oxygen, O2. What else are they going to do to him? Vital signs, monitor, EKG. Yeah, maybe an IV. So, absolutely. Are they going to give him any medication? TPA, Courtney. So that's what I was looking for. Do you think TPA would be appropriate to give this guy right now? Yeah? There you go. It's a great idea. However, we don't know if he's having a hemorrhagic stroke or an ischemic stroke, and the only way that we can tell that is from a CAT scan. So the problem is if we go ahead and give him TPA and then we get there and realize it's a hemorrhagic stroke, now we've created more problems. So yeah, TPA is a great thought. However, there are services like Atlanta, Grady Health System, they have a mobile CAT scan. So when they get a stroke alert, they drive this ambulance with a mobile CAT scanner in there. They get the patient in there, they do a spiral CT, they can tell if it's not a bleed, they can start TPA right there. So that's a whole different level of EMS. However, no, not in this particular realm, but what other things can we control as nurses? What's an important parameter for a patient, whether it's hemorrhagic or ischemic stroke, that we really want to be in tune to and kind of keep under control. What vital sign? We worry about his heart rate, respiratory rate, blood pressure, pulse oximeter. Yeah, it's blood pressure. Whether it's hemorrhagic or ischemic, that blood pressure is going to come and play a major role. So EMS, if they note that he's profoundly hypertensive, can give him some medication. We give him some labetalol. We can give him certain medications, that would minimize that risk. And when we talk about TPA or clot busters, kind of get him in that category of getting that. So great job. Yeah, I like the discussion on that. This right here just shows some differentiations, and this is more towards, say, rehab and kind of thinking down the line. So if we have a patient that had, left hemisphere versus right hemisphere, this is kind of the things we're going to look for. Any deficits, inability to discriminate words, letters versus personality, sense of humor. So we just know that when it comes time for rehabilitation, these are some of the things that we're going to expect to find with left versus right hemispherical strokes. Speaking of strokes, don't have one with this slide. Take a deep breath. You're not going to be responsible for the differentiation between a middle cerebral and an internal carotid artery stroke. This just kind of goes over the fact that that circle of Willis, that cerebral vasculature, is very extensive. But we do know, depending on the artery involved here, we can have some of the things that are come in that are going to find throughout this particular module, and some familiar terms like homogeneous hemianopsia. We spoke about that last week, and that's kind of losing your peripheral vision. So we have to worry about teaching these patients scanning techniques for safety, unilateral neglect or inattention. They can't feel or lose the kinetic sense of where their body part is. They're at risk for injury. These are some terms you probably recall: agnosia, ataxia, amnesia, aphasia. Again, those happen. This one I want to kind of point out here in the vertebrobasilar artery, but more importantly, the basilar artery here, the larger one up here. They can have a thing called locked-in syndrome. So if you get a large clot within that very large artery, they can have a thing called locked-in syndrome. These patients can't talk, they can't speak, they can't move, they can't feel, but they're completely awake, they're completely aware, they're completely lucid inside this body that cannot respond in any way, shape, or form. And you think of that, that's almost torturous. So that's like giving someone a paralytic and no sedative. They can't move, but they're fully aware. Those patients who were awake during surgery. There was if anyone's a metalhead, so Metallica had a song called One, and One was based off of a movie, which is based off a book called Johnny Got His Gun. And this guy was in World War II. He lost all his arms, he lost his legs, he was a quadruple amputee. He lost his eyesight, he lost his hearing, he lost the ability to speak, but he was completely lucid. And it's kind of him talking through this almost insanity to go through, being locked in a body and you can't communicate with anyone. But that's what locked-in syndrome is for a stroke, and it's devastating. And that's where really early intervention can help take someone from this life to something that's not that life, so where they can be communicative. When we talk about assessing strokes, we need something that's an objective tool, and the National Institutes of Health came up with that. It's called the stroke scale. It objectively quantifies the impairment caused by a stroke. Now, last week we spoke about the Glasgow Coma score, we spoke about AVPU. Those are like the snippets. This is the snippet in time. Okay, here's what his GCS is, here's what his AVPU is. This takes time. This really gets down to the nitty-gritty. It's got 11 separate items, each of which is scored between 0 and 4. And with each item, the lower the score, the better the prognosis. So it's between 0 and 42. 42 is the worst you can be. 0 is the best you can be. There's a link here that goes in the video. It's a very long video. It's not a quick test. This takes time to do. You have to be kind of credentialed to do it. So those of you who are interested in neurologic nursing or emergency nursing, this is something that you would probably take as a course, and you go through how to perform that. I do have just kind of a PDF of what to expect when you see it. And this is not for you. You don't need to understand and go through the nitty-gritty of this, but understand that it's not just a quick thing. Here it looks at the level of consciousness. Again, that's a pretty easy one, but then it breaks it down. It looks in their level of consciousness questions. Can they answer questions correctly? 1, 2. It looks at their commands. Are they performing them correctly? It looks at their gaze. Is it normal, partial, forced? Then we look at their visual fields. Are there any hemianopia? Do they lose any sort of peripheral vision? Palsies, is it symmetrical? Is it asymmetrical? And then we can kind of grade that. There is a level of subjectivity to this, as you can see. motor arm, motor leg, and it's broken down into left and right. Limitaxia, is it minor? Is it present? Is it not present at all? Then when we look at sensory, is it normal, mild to moderate, severe? And then language. Language has a whole litany of things that we look at for aphasia, receptive, expressive, global. We'll get into that, aphasic terms. Dysarthria, and that's, can we comprehend them? Is it very severe? Are they intubated? Can we even assess that? Extinction and inattention, so visual, tactile, or oriental, auditory, what are they looking at? And this is where some of these tools come in. They look at this picture. Can you tell me what the hazard is in this picture? And if they can or can't articulate that, what are these? What are they used for? And then speaking these to assess dysarthria. So the whole thing about this is it's not a really, really quick one and done exam, is it takes a while because we really want to assert and find out quantifiably and objectively how severe is this stroke that this patient's having. Any questions on any of that we've gone over so far? More importantly, am I going too fast? Good pace? Okay, good. If you need me to slow down, let me know. Perfect. All right, so here's those cranial nerves we spoke about in that video. Bell's palsy came in, and that's number one you're going to look at. Bell's palsy causes exactly what we saw in that video, facial paralysis, but it's cranial nerve number 7. It may affect 5 and 8, but it's mainly cranial nerve number 7. They get, all ages can be affected, but actually young adults, it tends to be more prominent in. They can't close their eyes, wrinkle their forehead, smile, whistle, or grimace, and it's unilateral. That's the difference between Bell's palsy and a stroke, is it's isolatory to the face only. Even though it's unilateral, even though it has all the classic symptomatology, it only stays in the face. It doesn't go beyond that. Trigeminal neuralgia is a little different. It's called tic douloureux, which is French for painful tic, and it affects cranial nerve number 5, or trigeminal nerve. What happens is it's this intense facial pain, and it's so intense it causes spasms of that one side of the face, so they crinkle their face up on that one side. And from an outside objective view, you look at someone who has now facial asymmetry. Granted, instead of being flaccid, it's tonic, so it's a cramp, but you see it makes the other side look flaccid. But it's only to the face. It's actually debilitating, the pain. And next week, we're going to go into that more. I'll show you some videos on how it's surgically corrected, which is far more invasive than you would think. But we can provoke this with minimal triggers like dental procedures can bring that on. And it's unilateral only and isolatory to the face. So we talk about emergent interventions for strokes. First and foremost are ABCs. Make sure their airway remains patent, that they're breathing fine, and that their circulatory status is intact. AccuCheck. It is really, really, really important to get an AccuCheck on these patients. Put this into a story. And I don't know if some of you were on this. I met my buddy Chuck. I brought him into a virtual clinical a few semesters ago. But Chuck's a flight nurse too. He's up in Massachusetts, but he flies out of New York. So he got launched out to rural New York State for stroke. Flies out there, they land, it's cold out. EMS, yep, left-sided, complete flaccidity, dysarthria, couldn't maintain her airway, suction, we RSI'd her, we intubated her, she's on a ventilator, she's sedated, she's packaged up, everything's ready to go, just fly her to the Comprehensive Stroke Center. Roger Dodger, they get her, they put her in the back of the helicopter, they secure her in, they secure themselves in. First thing he does is he checks her blood sugar. What do you think her blood sugar was? It wasn't normal. This woman had a blood sugar in the 20s. He gave her an AMPA D50, now wide awake, gets to the trauma center, they sedate her, they wean her off the sedation, they extubate her, she's completely fine. No strokes at all. She just had a blood sugar of 20 that required glucose. So that woman got like a $40,000 helicopter bill and was flown to a different city, to a hospital, because she had a low blood sugar, because EMS failed to just do the basics of checking an AccuCheck. So it's really, really important to do that. And the reason behind it is usually there's an underlying cardiovascular disease. You usually have some vascular problems, hypertension, atherosclerosis. But as their blood sugar starts to drop, one side of the hemisphere of the brain gets more glucose than the other. So that one that's starving for glucose starts to show the symptomatology on the contralateral side, facial droop, dysarthria, weakness, same exact symptoms as you would see in a stroke. So this is great for you if you're on a floor somewhere or a patient comes in with symptomatology of that. While you call rapid response, check a sugar. That's a very important thing to check because that's something you can intervene on. Usually there's standing orders to intervene with hypoglycemic patients. but that's a really, really good story to help bring in the focus that a simple AccuCheck may be all that's needed for those patients. Stat CAT scan, usually to get them within 25 minutes of arrival. Start 2 IVs for these patients. Why is it important for us to start 2 IVs? Any guesses? We got post-lunch sleepies here, I understand that. So 2 IVs are important in case we're given a medication. Let's say they fall into the parameter where they can have thrombolytics, but they start to decompensate. And we need another line. That's medication that might not be compatible with that. What if one goes bad? It's always good to have those 2 IVs and one's that emergent line for the patient. All right. Ischemic strokes. So we need to assess. There's no contraindications for starting thrombolytics. We'll get into the contraindications in a second. But it's important to understand that the time begins when the patient was last seen normal. So Gam goes to bed at 9 p.m. She's fine. She lays down. You go see her at 7 a.m. You knock on the door. No response. You go in there and she's got full right-sided flaccidity, all the signs of a stroke. You have no idea when she had the stroke. She could have had the stroke at 9:01 p.m. or she could have had the stroke at 6:59 a.m. You don't know. And the reason you don't know really changes whether she can get a thrombolytic. So it's over 3 hours, you can't give it. We'll get into that in a second. But it's really important to find out when the last time they were seen normal was. We can do endovascular interventions for these patients. We can do intra-arterial thrombolysis, so we can cannulate and actually take a small amount of that TPA or clot buster so it reduces systemic effects. We can do mechanical embolectomy and carotid stent placements. Has anyone heard of a mechanical embolectomy? Has anyone seen that? I got a video of an embolectomy. It's much more invasive than you would think. Okay, we saw that. We're on the side.
Both the frontal and temporal lobes respectively can be seen at this stage, as well as the finished dissection of the superficial temporal artery. In this case, the time period from the skin cut to the dissected superficial temporal artery was 20 minutes. This parameter is labeled STA ready and is always recorded in an operative note. Despite the surgery being performed after IVT, almost no bleeding was observed, with fibrinogen level being 300 milligrams per deciliter. A retractile Sylvian fissure dissection was carried out. The calcified lesion within the inferior division of the left middle cerebral artery was identified. The proximal control was achieved by temporary clipping. Due to the expectation of a poor backflow, no temporary clips were used for distal vessel control at this stage. Due to a resemblance to an atheromatous carotid plaque, a 5 mm longitudinal arteriotomy was performed. Despite the length of the incision, the retrieval of the individual calcified fragments was rather demanding and was only made possible after a significant vessel manipulation.
So they pick away at this thing for quite a while.
Used to intentionally flush out the potential debris residue with subsequent distal clip adherent calcified embolus is carried out.
And that's what they yank out. Look at how different that is.
The proximal control clip was intentionally temporarily removed in order to flush out any potential debris and reapplied subsequently. An interrupted 10.0 proline suture was used.
So you get the idea. This is an atheroma, which is a little bit different than a clot that would be in there. However, it's the same exact procedure, whether it's a clot or an atheroma, to get that out of there. It takes a while to get in there. I don't know if you heard him. It took him 20 minutes to get into that, just to get to that artery. And then they can start the embolectomy on that patient. If it's a bleed, we're kind of limited with options. Remember, all hemorrhagic strokes require some sort of surgery, whether it's a shunt that needs to be placed for some hydrocephalus, or if it's a clipping for an aneurysm, or a surgical evacuation of a large hematoma. So the ischemic strokes we have a little bit of play with. We can do endovascular interventions, or we can do TPA. When it comes to bleeding, we just need to get them to the OR. Speaking of TPA, tissue plasminogen activator, it's one of the requirements for TPA is that it's an ischemic stroke. We don't give it to hemorrhagic strokes. We kind of spoke about that earlier. Why? It'll exacerbate the bleed. That'll make a problem even worse. The onset of symptoms have to be less than 3 hours. Now the window's changing, 4.5 hours. Some people are pushing it out to 6 hours, but it all has to do with how tissue plasminogen activator works. Plasminogen inhibits fibrinogen to fibrin. So again, if we stop that, and then it breaks apart the clot, it stops the clotting process. But after 3 hours, well, it's kind of beyond that level in the clotting cascade, particularly. But they're saying maybe more and more, at least if we get something stopping, it'll be better. But 3 hours tends to be right now the uniform window, that if it's over than that, we're probably not going to need to do TPA. It's not going to work very well. The risks far outweigh the benefit. It's usually given within 60 minutes of arrival to the ED. We have a whole list of contraindications we'll go over in a second. But in the emergency department, again, they get that CAT scan within 25 minutes. Quite often than not, we'll take them from EMS, we'll go directly to CAT scan and just put them right on the scanner from there. They're admitted to the unit. We don't give them any anticoagulants for the first 24 hours after TPA. They're already at a high risk for bleeding anyway. We avoid any invasive procedures, again, risk of bleeding. And the important thing is we do neurochecks every 15 minutes for the first 2 hours, and then every 30 minutes for 6 hours, then hourly after that for 24. Why do we want to be so aggressive with the neurochecks for the first 2 hours? Anyone have an idea? Any guesses? Anybody awake?
Fully awake? No guess, though.
The guesses are we're giving something that causes bleeding. So you can take something we're treating for a thrombotic stroke, and we can give them a hemorrhagic stroke. So that's the problem. Within the first 2 hours, we're really, really in tune to that. So if we start to see their neurologic status, usually we're expecting it to improve, and it improves significantly quickly. But if it starts to improve and then it degrades really rapidly, the first thing that should pop into our head is, shoot, they're probably having an intracerebral bleed, notify the caregiver, they're probably going to go get a CAT scan, let's monitor their vital signs, but in particularly their blood pressure. Because again, hypertensive is going to bleed faster, and we can control that pharmacologically. Yeah, again, bleed, that's the thing, I worry about bleeding. So contraindications to TPA in a stroke, the first whole bunch really have to do with bleeding or potential to bleed. Did they have head trauma? Have they had symptoms that suggest a subarachnoid? Any arterial punctures in a non-compressible site in the past 7 days? Any intracranial hemorrhages in the past? Neoplasms, AV malformations, recent intracranial or intraspinal surgery? All of this says, hey, you're set up to possibly have bleeding that we can't control. Blood pressure. If systolically it's greater than 185 and diastolic, or diastolically greater than 110, they're out of the window to get TPA. So we can control that. We can control that aggressively like esmolol or nipride. We can bring that blood pressure down so they can get this life-saving drug. And again, it's not the only disease state where we may have to give medications to treat their vital signs in order to give the curative medication. Active internal bleeding, bleeding diatheses. This is where we look at some lab work. What is their blood work like? Is their platelet count okay? Did they receive heparin in the last 48 hours? So their PTT, is that above normal? Now, the good thing with heparin is we can give an antidote for heparin. Does anyone know what the antidote for heparin is? Vitamin K is close, but that's for warfarin. It's Coumadin, but good job. Heparin has a different antidote. It's given intravenously also. It's called protamine sulfate. So protamine sulfate, we can give that to reverse the effects of heparin. Vitamin K we give to reverse the effects of warfarin or Coumadin. But we have to give protamine. We give a very, very slow IV push because it can cause profound irreversible hypotension. And again, if they're on anticoagulants like say warfarin, we can give them vitamin K, we can give them fresh frozen plasma. But again, these are things that might just say, look, the risk is far going to outweigh the benefit. And again, any thrombin inhibitors, glucose concentration less than 50, they might just simply be hypoglycemic. And then if the CAT scan shows a lot of little infarcts, probably not the best thing to give them TPA. TPA in and of itself, it's been around a while. It's a very powerful thrombolytic agent, and it's used in the lysis of acute thromboembolism. They lack factor 11. Yeah, factor 11 is important too because that is part of the clotting cascade after your intrinsic factor. So yeah, that's going to cause problems actually that's going to cause problems clotting in to begin with. But again, if that's a bleeding diatheses, which that falls under, we don't want to give it. So good job, Christina. It was FDA approved initially. We gave it for myocardial infarctions. And I remember when it came out, I was working in that ER in Connecticut looking like a serial killer. And I remember we had this MI patient came in, and it was really, really regulated. It was really, really, really expensive at the time. Pharmacy would come up. It was in a locked box, and the physician had to draw up, give the bolus, IV, then we started them on a drip. I mean, it was a big deal to give TPA just because it was so expensive. Here's a lesson learned. So I was all excited. It was the first time we're giving TPA. Got the patient set, got him on the monitor, got on my pump set, got everything set to go. And doc draws up, he starts to flush it, and then the whole bed gets wet. Everything was set up except I failed to look at that IV. The IV was patent, but one of the connections was loose. When he started to push it, it disconnected. So we pushed a bunch of TPA onto the mattress. Oopsie, expensive, patient didn't get it. Luckily, pharmacy had another vial right there. But it's important to understand, don't become part of the emergency. Do your due diligence, make sure each and every time. It's easy to get caught up in the excitement of an emergency situation, particularly when you're young and you're new and you're out there. But hey, learn from my mistakes. But the good thing about TPA is they really expanded its use for pulmonary emboli, for ischemic strokes, and even IV catheter patencies. These patients go through a lot of pain and effort when they get these indwelling long-term catheters, and if they become clotted, they don't want to go through that again. So we could actually give them one of these TPA or streptokinase or something to actually break apart the clots that are in there. Kind of dovetailing on that, who here knows what a Joint Commission is? One word for Joint Commission if you want to put it in your chat box, if anyone's familiar with it. When they hear the word Joint Commission. Safety, audit, drinks at the safety. Yeah, their overall thing for Joint Commission, it is a commission. They're a regulatory body. They come in. Most nurses who've been around it initially want to say, oh, okay, no food or drink at the nurse's station. They're measuring things from the ceiling. So they're looking at some of these obscure safety measures, which, Joint Commission has lost a little bit of credibility during the pandemic because they kind of scattered. However, the goal is exactly what you said. They do audits to make sure that everything's running safely and it adheres to regulations or core measure sets. So what they do is they go into the hospitals and they do these evaluations, and they want to make sure that the minimum bar is set. So when you meet the minimum bar, you are eligible for federal funding. Medicare, Medicaid patients, you can get reimbursed. If you lose that, if you fail to meet that, that is a massive financial hit to any institution that is not getting reimbursed for Medicare, Medicaid patients. With that being said, one of the things they look at are core measure sets for stroke patients. So there's a bunch of them in here, and it has to do with systems set in place for your patients. First off, make sure you have venous thromboembolism prophylactics, that's compression devices, sequential compression devices, that's low molecular weight heparin that these patients can be on. Make sure that they're discharged on an antithrombotic, antiplatelet therapy like Plavix or aspirin, that you have anticoagulation therapy for atrial fibrillation and atrial flutter patients, that there's thrombolytic therapy available in the hospital for patients with acute symptomatology. You have antithrombotic therapy by the end of hospital day 2. There's statin medication if their cholesterol is running high. There's an education program built in for the patient and also their family, and they're assessed for rehabilitation. Remember, prevention techniques, primary, secondary, and tertiary prevention. Tertiary prevention is this: it's rehabilitation prevents secondary problems related to the stroke. And locally, we look at, South Bay Hospital has the same thing, and it follows exactly what the Joint Commission has. They just make sure that they differentiate it. They have sequential compression devices. They have, anticoagulants. So if they're sent home, talking about what you said, if they're sent home, what is the lab result we want to look at when they're on heparin? They're in the hospital, we put them on heparin. What lab do we follow for that? Any guesses? What lab?
APTT?
You got it. PTT, excellent. Partial thromboplastin. What about Coumadin?
INR?
Yeah, the INR. Perfect. The INR, PT. Excellent.
I'm glad I got that. I usually mix it up.
Yeah, no, you got it right. Yep, PTT for heparin, and warfarin is the INR, the International Normalization Ratio. Again, LDLs, they have a statin for it. And here's the big thing about education: signs and symptoms, disease process, risk factors, and when to call 911, not only for the patient, but for the family also. So here's a question: what physiologic parameters should the nurse control in stroke patients? Heart rate, blood pressure, respiratory rate, or temperature? 1, 2, 3, or 4. Yep. I got 2, 2, 2. Yeah, blood pressure. Absolutely. That is one thing that's integral that we can control. It's funny, blood pressure's come up a lot within this lecture. What tests are performed on all patients presenting with CVA signs and symptoms? An EKG, chest x-ray, blood glucose, or ABG? Every single patient, which one do they get? Yep, 222 glucose. Absolutely. Glucose, glucose, glucose. Not everyone's going to get a chest x-ray or an EKG. However, everyone should get a glucose. All right, we're almost done. We'll take a break. Post-stroke interventions. So the risk for dysphagia. Again, aspiration is a problem. Tuck the chin when they're swallowing. Sit them up when they're feeding. Solid food on the unaffected side of the mouth. That homogeneous hemianopsia. Teach the patients to turn their head left and right. Lost those visual fields. Address the affected side first. And then assess for unilateral neglect, which is any issues, trauma, infections on the side they can't feel. And we want to turn them every couple hours and really look at the skin integrity. Speech therapy, PT/OT, I told you they come back. That really helps with mobility, particularly with customizing splints. And we want to elevate the affected arm to prevent edema. Range of motion exercises that we can do for the patient, they can do for themselves, and the family can do. And again, here's a link for a lot of great interventions. So here's a SATA. What interventions can the nurse provide to reduce aspiration? Have the patient tuck their chin when swallowing, lay them supine when swallowing, place food in the unaffected side of the mouth, mix liquids and solids, offer small bites. Which ones do you think minimize or reduce the risk of aspirations? 1, 2, 3, 4, 5. Which ones of those? Multi-select. 1, 5. Everyone agrees 1? Yeah, 1, 3, 5. You got it. Yep. We don't want to lie flat, and we don't want to mix liquids and solids together. This is a great time to take a break. How does that sound? Break sound good? We'll come back in 10 minutes. Let's make it 2:13. Everyone come back. Sound good? Awesome. All right. Welcome back. Hopefully you had a little stretch, wake up this afternoon, siesta, whichever makes you feel better. All right, moving on, we're going to talk about stroke patients and impaired communication. First and foremost, we're going to talk about aphasia. So aphasia in and of itself is this inability to express or receive verbal communication. And it's broken down into categories. So we have expressive aphasia, which is the Broca's aphasia. It affects the Broca's region of the body. And again, aphasia happens whether it's expressive or receptive because there's an inhibition of the blood supply to that area. So it causes a little bit of hypoxia, anoxia, or ischemia, and that's where it becomes affected, and that's where we see it. So expressive aphasia, they have the inability to express thoughts, difficulty speaking and writing. So it's very frustrating for patients because they'll show you a pen and all that can come out of their mouth is comb. And they know it's not a comb, they know it's a pen, but they can't articulate that. The opposite is receptive aphasia. This is Wernicke's aphasia. This happens in the Wernicke's area. So it's a comprehension problem. They have difficulty understanding written and spoken words, so speech is often meaningless to them. You know, you're telling them something that they can't process that at a neuronal level, so they don't know what you're saying. And then there's global aphasia. It's both expressive and receptive. There's profound speech and language problems. Often speech and sounds are not understood verbally and receptively for these patients. It's devastating for them. So when we have a patient with aphasia, some of the general interventions we can do is speech therapy. You know, we can help them help themselves, reduce background noise, keep it simple, express one idea at a time, use simple one-step commands, and one task at a time. Speak slowly, use cues or gestures, and we don't rush the patient when they're speaking. Again, it's one of the things where our patience needs to come into play. And use adult language. Don't talk down with them. Those of you who work clinically, if you've ever seen somebody do baby talk to an adult that has either aphasia or English as a second language, it's demoralizing for those patients. It's really not the best thing. I mean, don't fall into that trap. The other thing that people do with that is, and they just yell at them. You know, expressing your voice loudly is not going to change the comprehension problem of these patients. It's important that we get their attention first before we commence a conversation so they understand that a conversation is going to happen. Keep your voice at a normal tone, a stable volume, and establish the topic of conversation with the person prior to and during the conversation. We want to ensure that any sensory aids are within reach. If they wear glasses, put them on. If they have hearing aids, put them in. Dentures, it helps them articulate a little bit better. So expressive aphasia, that Broca's aphasia, we want to give them alternate forms of communication, such as a computer, handheld mobile device, communication board, flashcards, pictures are phenomenal. Receptive aphasia, the word keys, we want to use gestures. We want to write down keywords when we're speaking with the patient and talk about things that are relevant to the current context. If you're at the dinner table asking them if they would like a drink, kind of makes sense in the context versus do you like baseball? Slow your rate of speech, and as the patient cannot process the speech as quickly as they used to, so importantly, don't talk down to the patient. Maintain eye contact. This helps give that patient context clues. You'll be surprised how many people with hearing deficits read lips. I didn't realize how bad my hearing was until I took a job in a cath lab. Most of the cardiologists were predominantly Indian, very soft-spoken, a little mumbly at times, and then you threw a mask on them. I had no idea what they're saying. None. And it wasn't their problem, it was my problem. So that was where the issue became that those context clues and being able to read lips came in very, very important. Any questions with the aphasia? Okay. So, quick question. In Broca's aphasia, expressive aphasia, what communication adjuncts can the nurse use? It's a SATA. Use gestures, offer communication board or computer, slow your rate of speech, and I think this is going to auto-populate the answer. Yeah, use pictures. For some reason I can't change it in this under back running algorithm. It just won't let me change that. So yeah, we want to offer communication board or computer and use pictures if necessary. Risk factors. It's important to understand the difference between modifiable and non-modifiable risk factors, and there's definitely a difference between both of them. So modifiable risk factors, hypertension. Now, I know you're going to say, well, hypertension can be essential. That's not a modifiable risk factor, but it is. We can modify that by being compliant on a medication regimen, changing lifestyle, whatever we can do to help that hypertension. Same with hypercholesterolemia. Diet, exercise, medication compliance. Atherosclerosis, same thing. Atrial fibrillation, that's another one. Well, they can't control having atrial fibrillation, no, but they can maintain their INR within a normal range. They can eliminate high vitamin K containing foods. They can use a consistent diet. Obesity, drugs and alcohol, diabetes and sickle cell anemia, again, reducing triggers, and diabetes keeping it under control, monitoring your A1C, watching what you eat, using your insulin or oral agents appropriately. TIAs, understanding that that's a wake-up call, that's your chance to get in, get it taken care of, let your physician know that these are happening. And smoking and oral contraceptives I'll kind of put together. I put Donna's story in here because when I was about 15 or 16, I think I was 16, and I was on an ambulance, looking at that picture, and we got called out. My partner was Jim Garrow. Love Jim. Jim and his wife. Jim was a paramedic. His wife was a nurse, an ICU nurse at the hospital in Bristol. And I idolized these two. They were my heroes. They were my mentors. And they had a new baby, Michael. And Jim and I were on call one day, and we're at the ambulance corps, and we get toned out for somebody down in the street. So we go lights and sirens. We get there. Well, sure as heck if it's not Jim's wife. Jim's wife in her early 30s, 31, full-blown CVA. Right-sided deficits, dysarthria. I mean, just completely flaccid on the right side of her body. She was walking her baby at the time on a road with a hill. Luckily, someone was nearby. She fell down. Somebody caught the baby in the stroller, called 911, got her in the back of the ambulance. And this is the first time it really, really hit home to me. I mean, I'm 16 years old. To me, stroke was like, oh yeah, somebody's having a stroke. It's not like you're having a heart attack. It was devastating to me. I mean, this is one of my mentors, my idols, was just incapacitated completely. Got her to the hospital. This was before thrombolytic therapy. This was before interventional neurology existed. So basically, we sit there and we did blood pressure control, and she wrote out this stroke, which was a massive stroke. She was in rehab for many, many, many months. So my hat's off to speech, OT, PT, because Donna, who was this very vibrant ICU nurse, was incapacitated and bedridden. And after her months of rehab, she was able to speak coherently, walk with a cane, and she went back to work as a nurse. She went back doing case management, but was able to contribute into the career that she loved, and was able to bounce back from that. So her underlying risk factors were early on when she was younger, she had smoked and was on oral contraceptives. And we know now that those two are synergistic and just really, really, really magnify the problems of potentiating a clot. And that's what she had. She had a very large ischemic stroke from that. Some non-modifiable risk factors are age and sex. Again, men tend to have it a little bit more than women. However, women die more often than men from strokes. A family history, past medical history of a stroke really sets you up for another stroke, specifically if you had it within the past year. Fibromuscular dysplasia, patent foramen ovale, that's a hole between the atria, can set you up. Again, that's a very fixable procedure now. It's done 30, 45 minutes. You're wide awake when it's done in a cath lab. Then we want to talk about prevention. So diet and exercise, we know, stop potential causes of the stroke, hypertension, keep that under control. All these things that we spoke about, which are modifiable factors, modify them. Reduce the hypertension, again, by being compliant. And then they can do a thing called a carotid endarterectomy. Has anybody heard of a carotid endarterectomy before? Aside from being kind of a fun word to say. Affectionately, they call it the old roto-rooter job. Anybody? Got a quick video of what a carotid endarterectomy looks like. So most people think that a carotid endarterectomy is simply, they go in and they kind of do this roto job and they break up the clot. It's much more involved than that. So if you have a patient that goes for a carotid endarterectomy or post-op from a carotid endarterectomy, I think it's important for you to understand the procedure that they're going through because it's quite extensive.
Start the arteriotomy, number 15 lane, and extend the incision along the length of the anterior lateral side of the carotid artery with angled scissors. Then, begin to separate the atheroma from the intima and media with a free elevator. Often, the plaque will extend into the external carotid artery. This can often be left untouched. Stenosis located here is less clinically significant than when it occurs in the internal carotid artery. The internal carotid artery has no branches distal to the common carotid artery bifurcation, which makes the narrowing and buildup of plaque in that vessel more problematic. Remaining segments of plaque.
It's a significant amount of plaque that's in there. Huge.
Carefully feather each to create a smooth slope from the intima to the adventitia, which is now fully exposed. In order to prevent the creation
So what a difference that is with that cleaned out and how big that plaque was and how long it was within that vessel. So you can definitely see the problems that can come with that big, large plaque. But that's an endarterectomy. It is an open wound. They cut open the carotid artery. They do one at a time, obviously. So if there's an issue, they still have one viable, albeit sclerotic artery. But being able to go in there and clean that out is significant for those patients. It's going to be huge with their quality of life. So that's one of the preventions they can do for patients. And we monitor for them for stroke. We monitor them for bleeding, because the bleeding's also within that area. It's going to bleed within that neck area, so it puts them at risk for airway compromise with a hematoma formation. So post-operatively, they're kind of tricky patients we really need to keep an eye on, aside from opening up and bleeding. And there's other things we do, stents for atherosclerotic buildup, and they're in the carotid artery themselves, these angioplasty and stent. And we think of angioplasties and stents, we think of the heart. People having a heart attack or coronary artery disease, they go to the cath lab, they go in there, they find the plaque, they balloon it open, they put a stent. Yay, they're all fixed. They can do that in the carotid artery too. The patients are wide awake when it's done, and we need to do that. We'll talk about that in a second. But it's important they're awake during the procedure because we need to assess their neurologic status. Teaching post-operatively, or not even post-procedurally, is they need to report any of this. Severe headache, changes in loss of consciousness, muscle weakness, motor dysfunction, severe neck pain, swelling at the neck incision site. Again, we worry about bleeding. Hoarseness or difficulty swallowing. They may have some nerve damage underlying. And they may have this thing called hyperperfusion syndrome. Hyperperfusion syndrome is kind of weird. It has a really high mortality, really high morbidity rate, and it has to do with the cerebral perfusion. That brain is so accustomed to having reduced blood flow that when all of a sudden you open it up and they get normal blood flow, it really doesn't know what to do. So they can have severe headaches, hypertension, they may have seizures, they can have a lot of focal neurologic deficits, and it can occur within an hour after the procedure or up to a week or more after the procedure. And that's the dangerous thing. So that's where that client teaching and education really comes into play. If you haven't seen a carotid stent, I got a video on that one too. You find the videos helpful, yes or no? Yeah. Yeah, a lot of people are visual learners, and I can talk about it all day long, but I think they're pretty cool. So this is a carotid stent placement.
Which was done through
You can see the stenosis there.
approach. You can see that the lesion is profiled and a 5F Simon 1 catheter was used to cannulate the left common carotid artery. Now you see another view of the same lesion. A 0.032 standard wire was negotiated through common carotid artery into external carotid artery. And now Simon 1 catheter was replaced by a 5F JL4 diagnostic catheter and a 6F pinnacle sheath 90 centimeter long was negotiated into the left common carotid artery using the telescopic technique. Now you see the telescopic technique is in progress. We have now put a 6F pinnacle sheath in situ. A 0.014 BMW PTCA guide wire is negotiated in the left internal carotid artery through the lesion. Now the distal protection device is deployed. This is another view. A PTA catheter is negotiated across the lesion. Ballooning of the lesion is done now.
This is the angioplasty portion. You can see that balloon open. The patient's wide awake for this procedure.
This is the balloon result.
So it opened it up
We
significantly.
have now negotiated a self-expanding stent. Stent is now deployed. Post-stent balloon dilatation is in progress. This is an excellent end result. And this is the another view showing the result.
So you can see that made a huge difference in that really, really tight carotid lesion. And as you saw during that fluoroscopy, that patient's moving. So when they ballooned that open, do you think they felt it? I mean, you saw the jaw movement and everything. But that is a carotid stent placement. So that really, really tight lesion is now way open. But understand that they balloon it first to smush that plaque. They put the stent in it and they balloon that stent so it locks open and in place. So it's really, really cool that we can do that now with the technology that we have available. So a quick question here. Let's see. Stents. Boop, 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 boop. All right, we have a quick case study we'll talk about. You have a 67-year-old female, history of hypertension, diabetes. She's got a BMI of 40, experiencing headaches for the last several days, intermittent slurred speech, which was resolved. And about an hour ago, she's at her work desk. She falls over. EMS transferred to the ED. She's expressively aphasic, slurred speech, right-sided hemiparesis. So what do you think's going on with Carmen here? She having an MI? Probably having a CVA. So what's the desired outcome as well? We want to get her back to baseline. But what are her risk factors? What's the risk factors that you see in Carmen's history that set her up for this? Yeah, the BMI, so obesity, hypertension, elevated BMI and age. There's the other one there. Anything else? Diabetes, non-compliant. So actually, I'm going to stop for a second, and I see non-compliant diabetic. Christine, I'm not going to pick on you, but I want to point this out because this comes into test taking. It doesn't say she's non-compliant. It says she's got a history of hypertension, diabetes, and I want to point this out because it's not uncommon for reading into a question. And when you're taking the test, particularly with MDC4 questions, be careful about reading anything into the question. We can assume maybe she's non-compliant, but it doesn't say that. However, you're right that she's diabetic. The other thing is she's had headaches off and on with slurred speech for the last week, last several days. What is that? Yeah, she's having TIAs. Hey, wake up, there's something wrong. So emergent interventions that we would do as Carmen's coworker would be what? She's at the desk next to us, she flops over. What should we do? Tackle her? Wrestle to the ground? Yeah, lie her down on her side. Think ABCs, safety, 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 lie her down, call 911. But yeah, you point out all the risk factors, so good job with that. All right, any questions about strokes and TIAs? Feel pretty good about it? Content's a little bit easier this week to digest than last week because it's a little more familiar. All right, am I going at a good pace, or do I need to slow down? Good, okay. Well, let's transition on to headaches. So headaches are they can be acute, they can be chronic, temporary, they can be life-threatening, like a subarachnoid hemorrhage. There's primary headaches, which really have no organic cause, but they're migraines or tension-like cluster headaches, or secondary headaches. They're associated with an organ or brain tumor or an aneurysm. There's some underlying pathology that we can put our finger on. And of course, there's nursing school headaches, which are very different. And that's actually in this pictograph. You have migraines, hypertension, stress, and of course, nursing school, which is a whole different level of type of headache that we're doing. So the categories, when we talk about migraines in and of themselves, there's migraine with an aura. And again, talking about last week, we had seizures with an aura. And an aura can be anything that patient or that client sees, smells, feels ahead of time. It can be auditory, it can be visual, it can be somatic. They have something that says, hey, there's a migraine coming on. Much more common are migraines without an aura. By far, much more common. And then you have atypical migraines. There's a few of them that fall into this weird category. They're very rare, but they're there. So when we talk about migraines with an aura, the typical phases are that prodromal phase. That's the first thing. Happens several hours, maybe a day before. They know something's coming on. They're maybe irritable, depressed, food cravings. Everyone's a little bit different. But they get this aura. And when that aura develops, it's usually over several minutes. Usually doesn't last more than an hour. The pain is preceded by either visual, auditory, some sort of aura. And it's unique to that patient. Neurologically, they may have numbness or tingling of the lips and tongues. They may have confusion, aphasia, vertigo, unilateral weakness, or drowsiness. And then it slips into that second phase. That's where they get that severe, incapacitating, throbbing headache. It intensifies over several hours. It's usually accompanied by nausea, maybe vomiting, drowsiness, vertigo. And that lasts until the third phase. Usually about 4 to 72 hours is that third phase, where they just have this dull, persistent headache. The aura subsided. They usually have muscle aches, head and neck muscles. They're sleepy. A student in the morning's class has migraines and said every time she has one, it feels like she got hit by a Mack truck. So I've worked with coworkers who've had migraines, and yeah, I knock on wood, haven't had them, but I can tell you it's debilitating. A visual migraine is something that they can just have the aura, but there's no pain. So it's usually experienced by older adults, not that common. So the more common one is no aura. It's a typical common migraine headache. It's pain. It's usually aggravated by physical activity. It's unilateral, pulsating pain. One or more of these signs and symptoms may be present. They don't like lights, so they're photophobic. They don't like sounds, so they're phonophobic. They may be nauseated. They may have accompanying vomiting. Lasts 4 to 72 hours. And it often occurs in the morning or during stress, sometimes with premenstrual tension, fluid retention. So those are the common ones. And then you have your atypical category. There's one called Steiger's migrainoris that lasts longer than 72 hours. There's a migrainous infarction, and that's a scary one because you have neurologic symptoms that, if not within 7 days, are non-reversible. So they actually have ischemic infarct and neuroimaging, stroke following migraine. It's really rare, but it can happen. And then you have these unclassified ones. They don't really fit into any of the category. They'd be classified as a migraine. So if we know what it is, we know it's a migraine, whether it's with an aura or without an aura, we know that there's some interventions we can do. So we think of abortive therapy. Abortive therapy is it's already happening. We need to abort. We need to stop. We need to get rid of that. And pharmacologically, we can give them some medications. We want to alleviate the pain during the aura, ideally. This way, when it slips into that second phase, If they have an aura, then we can minimize that. So if it's a mild migraine, well, we don't break out the big guns. We start low. Acetaminophen, some non-steroidals like ibuprofen or naproxen. We can give them Excedrin that has acetaminophen, aspirin, and caffeine, which is a vasoconstrictor. We can give them antiemetics. Again, if they're feeling nauseated, let's take away that one symptomatology that we know we can. If it's a severe migraine, well, now we got to dig a little bit deeper pharmacologically. We give them the trypsin solutions. These activate receptors in the cranial and basal arteries, and they cause vasoconstriction, profound vasoconstriction. Sumatriptan, which is Imitrex, that's one of the earlier ones that came on the market. Now it's oral nasal spray, but it used to only come in injection. And we know that it can cause chest pain, so if it's contraindicated in any type of ischemia, cardiac, brain, and peripheral. When this first came out, we had a whole room in that emergency department designated to patients getting Imitrex. We had a 12-lead EKG on the whole time, full complement of SpO2, EKG, oxygen, everything, because we were told they're going to have a heart attack. So if you give Imitrex, they're going to have a heart attack. Well, we know that that's not the case now. We know that we can weed out those patients who have underlying ischemic issues, and then it's a safe drug to give those patients. Ergotamine preparations, they constrict blood vessels, and they also reduce inflammation. I think of ergotamine because I just think, hey, I got a headache, I'm going to take ergotamine. It's abortive therapy, it's not preventative. Cafergot is one of them, and it's a start of the headache, and you can give it orally or rectally. It's good to have other options than oral, simply for the fact that they're nauseated and they may vomit. So a rectal option, as we know, is it's highly vascular, it's absorbed very quickly, but it's a good alternative. There's also dihydroergotamine, which can be intravenously IM or nasal spray. Isomethicone and dichlorphenazole combination. Again, I think they just put those words to see if I can say them, which is Midrin. It's another medication. So know that there are options for these patients, much more options than there were before. The other thing we can do is if they're not having an active migraine and we want to prevent migraines, and it's usually those patients who have more than 2 a week, it interferes with their ADLs, it's not relieved with the typical treatments, we can put them on some prophylactic therapy. Non-steroidals, again, if they're on a non-steroidal every day, we need to monitor for bleeding, so they need to check their stools. If they're on beta blockers, calcium channel blockers, these reduce the activity of hyperactive excitable neurons, so they act on the neuronal cases of migraines. Beta blockers, the only two available are propranolol and timolol, the only ones approved for migraines. And the calcium channel blocker we're going to use is verapamil. So you take them even if they're not feeling well, even if they're feeling well. That's the important thing. It's kind of like these anti-epileptic drugs. Well, I haven't had a seizure. Well, I stopped taking my drugs. Well, you had a seizure. I haven't had a migraine because I've been taking the drugs, so I'm going to stop. Well, guess what? You're going to have a migraine. Topamax is an anti-epileptic drug. We use that in low doses. Same with nortriptyline. Again, it reduces the migraine episodes. Onabotulinum toxin A, this is Botox, basically. So what they can do is for chronic migraines, they can inject this, and you get a free Botox treatment, but it paralyzes the muscles around, minimizes the triggers of the tension headache that can lead to the migraine headache. Preventative interventions, have them keep a diary. There's going to be triggers for these migraines, so if you know what the trigger is, you can avoid it. One of the main things are tyramine-containing foods. I alluded to this last week, that we're going to need to know that, not only for those antiparkinsonian drugs, but for migraines. So those are those aged, fermented, stored for long periods of times. They're not fresh pickled products, beer, wine, aged cheeses, and nuts. So I would highly encourage you, again, to know tyramine-containing foods, because you may see a question about that. Here's a link that you can give to different tyramine-containing diets, avoiding diets, rather. Other things to avoid: cigarettes, contraceptives, hypertension. And we can do things like external trigeminal nerve stimulation. It's this headband, and it stimulates nerve branches of the trigeminal nerve. Use it no more than 20 minutes a day, or really how it's recommended. We can do complementary and integrative health, which used to be the, hippie health, as they would call it, but it's not. It's mainstay now. Yoga, meditation, massage, exercise, biofeedback, acupuncture, and pressure. We do know that these offer a very, very, very therapeutic purpose for these patients and for many disease states. We can give them supplementation for magnesium and vitamin B12. And in severe cases, we can do resection of the trigeminal nerve. Next week, when we talk about peripheral nervous system disorders, and particularly trigeminal neuralgia, when we get into that a little bit more, I actually have some videos on what the surgeries are. If you've downloaded this PowerPoint earlier, I've replaced it today with this PowerPoint. Again, I always try to look to offer you more things. I found this, and I put a couple other things in here. So this is just a visual aid to help you study those tyramine-containing foods and avoidance triggers for foods for migraines. Other interventions that we can do as nurses, put them in a quiet place. Quiet, keep it dark, give them a towel to put over their eyes, elevate the head of the bed, again, let gravity help you out. Cold therapy, give them an ice pack. Again, ice is a vasoconstrictor, so it's going to help with that. So which foods contain tyramine? Aged cheese, caffeine, artificial sweeteners, pears, pickled products, wine. Select all. Which ones do you think contain tyramine? Aged cheese, caffeine, artificial sweeteners, pears, pickled products, wine. Any guesses? Pickled products, wine. 1, 2, 5, 6. Yeah, good job. Yep, exactly. Caffeine and artificial sweeteners do not contain tyramine. Everybody good with migraines? So right off the bat, we're going to be finishing early today. If you're okay with that, not incredibly, but we're plugging on in. So everyone ready to move on into head injuries? Off we go. So it's important to know here when we look at this anatomy, this is not an anatomy class, but just to get everyone on the same page, we have a lot of protection to this noggin here. That brain is very pliable. We have this really thick cranial vault, that skull. Over the skull we have scalp, we have the meningeal layers underneath, we have CSF, and then we have the brain tissue. That CSF is there, it's nice fluid, it's a shock absorber for that brain. It does move around in that cavity. When we look at the base of the skull here, this foramen magnum is really, really important. This little hole just above it is the brainstem, the cerebellum, and when we have intracranial pressures that increase, and we spoke about either umbilical herniations or transtentorial herniations, this little hole is where pieces of the brain start to get squished through, and that can be devastating. So first thing we'll talk about are skull fractures. Now there's a linear skull fracture. Those are this non-displaced fracture. It goes through the entire thickness of the skull, but it's not movable. It stays in place. It's notable. Our depressed skull fracture, like this picture on the right-hand side, there's pieces of fractured bone extend below the surface of the skull. It may cause a laceration of the dura mater and brain tissue injuries. So again, it's a much more invasive, and it may have underlying bleed. So signs and symptoms of that are headache, surrounding soft tissue injury, a palpable depression over the skull. So I'd be remiss to say, do you think you should poke your finger in a depression? Probably not. Funny story about that, when we talk about open skull fractures is the same way. This is an open skull fracture. So here the fracture, the skull is there, you see brain tissue ballooning out, and post-mortem you can see how it mushrooms out. That's how much that brain is swelling. I was taking care of a patient in South Florida, our area, and he was a self-inflicted gunshot wound to the head, put a large caliber pistol to the right temple, pulled the trigger, came out of the left temple, came out of the right temple, lacerated his middle meningeal artery, and had an open skull fracture with that exit wound. So the patient was in cardiac arrest. As soon as we landed, we ligated the artery, gave blood, TXA, tranexamic acid, which is kind of promotes clotting. We gave him platelets, we gave him plasma, fluid, central line, all the whole gamut, intubated RSI. We got him back, we're flying him back to the trauma center, and this is what his brain looked like. So we're sitting there looking, and you can see it ballooning out of that right temporal area. And it looked like, if anyone's ever played dodgeball, those dodgeball balls, and it was just massive, ballooning out of the side of his head. Landed at the trauma center, bring him over to care, and talk to the trauma surgeon, let him know what we did, and then in comes an anesthesiologist, and he comes waddling in, and he looks at the patient, and he takes his index finger with a regular glove, and he just starts poking on the brain, like squishing a ball, up and down, like a little trampoline, and his words of wisdom were, "This is not survivable." And then he turns and leaves. So, poor form. I wouldn't go touching a brain, hanging out. But it begs the second question. It is not a survivable injury at all. Why did we go to such great lengths to save that person? Does anyone know why? Why would we use blood, such a precious resource, plasma, a precious resource, let alone all the drugs? Yeah, Denise, absolutely. Organ donation. just because that patient may not survive long-term that injury, that patient can help scores of other patients as an organ donor. So yeah, it's our responsibility to do the best we can, but to understand that even if it's not for the better of that one, it can better a lot. And when it comes to organ donation, I think it's important to understand that just because you're licensed as you're an organ donor doesn't mean that we take your organs. We don't immediately donate. We have to get consent from family members to do that. So even if you say it on your license, it just helps them give the opinion to say yes. There's a formal process to go through. It has to be brain death, all that other stuff. But yeah, exactly. It's our responsibility, 100%. But I got into a discussion with my medical director about it. He said, why'd you give him TXA? Why'd you give the blood? Well, the last rig is, middle meningeal artery. That's why I gave the blood. He was hypovolemic on top of the brain injury. But as we discussed, this patient's for organ donation. And that's a much greater cause, and we need to understand that. Sometimes we create an open skull fracture to help with the swelling. Because if the swelling's happening and it's an intact skull, again, Monroe-Keeley doctrine, the brain's going to go somewhere, let's open up a piece of the skull and we allow that brain to swell outside rather than going through that foramen magnum and causing a herniation syndrome that's going to be detrimental or even fatal to the patient. So this is a procedure that we can do to actually open up the skull to allow it to do exactly what happened with that patient we flew in, but it's allowing the brain to swell outside of that cavity and not cause compressive forces. Another skull fracture that we have is called a basal skull fracture or basilar skull fracture. It's a fracture of the base of the skull. It's usually caused by considerable force. It results in punctures or lacerations to the brain tissue and the cranial nerves, and you get cerebrospinal fluid leakage. It can cause a laceration to the dura mater, and that creates an open passage for CSF to leak. And again, now it's a conduit for infections, such as meningitis, encephalitis, brain abscesses. And they cross the carotid arteries. But the signs and symptoms that we see with basilar skull fractures are pretty unique. Headache, dizziness, hearing loss, altered mental status. Yeah, that can go with a bunch of head injuries. But when we start seeing cerebrospinal fluid in the rhinorrhea, rhino, nose, so in nasal secretions, or otorrhea, odo, ear, or leaking from the ear. Look at this thing called periorbital ecchymosis. It's called raccoon's eyes. And you can see this in the right-hand picture here. Very, very indicative of a basilar skull fracture. Also a thing called battle signs, which is mastoid ecchymosis behind the ears. These two things are hallmarks of basilar skull fractures. Bleeding behind the tympanic membrane. If you put a otoscope in there, you can see that dark red tympanic membrane. We may get some facial nerve palsies. But when we have fluid leaking from the nose or ears, we want to test it. Is it nasal secretions or is it some fluid out of the ear that we don't know? Well, we can do a thing called a halo sign. We can take that fluid, we can drop it on a filter paper, and if it starts to spread out where the center stays dark, red, and then it's yellow, hazy on the outside, creating a halo around it, very indicative that it's cerebrospinal fluid. The other thing we can do is check it for glucose. There's no glucose in nasal secretions and ear secretions. There's no ear secretions, period. But if there's a presence of glucose in there, again, another confirmatory measure that it's cerebrospinal fluid. So with that being said, we don't want the patient to blow their nose. If it is coming from the nose, we gently wipe it away. We tell them not to blow it. We don't use suction to get it out. And we don't use any pressure bandages on those. We want it to leak out slowly, catch it, but not inhibit it. Again, this on the right here, you can see indicative. This is a real halo sign here. This is a picture of it, and these two here. Different colors, but you can see that halo are on the outside of the blood. Very indicative of it. Again, here's another halo sign here. This is some otorrhea, and this is that battle signs, that mastoid ecchymosis of a basal skull fracture. Meningulators. Again, we spoke about all these protective things of our brain for traumatic brain injury. I think people don't understand, they underestimate how thick the scalp is. If you put your fingers on your scalp right now and you touch on your forehead, it feels like, what, 1 millimeter, 2 millimeters before you're touching skull? Here's a funny story about that. I was launched out, was flying in Pasco County. Are you okay with the stories or not the stories? I can bypass the stories if you want. Yes, stories. Okay, cool. So it's my day before I'm going on vacation. I got 2 weeks off, going to Canada. We're going to a cabin up in the woods. It's fantastic. So it's like an hour left before my shifts end. We all had that feeling, oh, okay, my shift's coming to an end. It's like 15 minutes before my relief gets there, we get toned out. For scene call, Bay Flight 1, Pasco County. Okay, that's all we get. So walk out to the helicopter. I'll admit, I walked a little slower, waiting for my relief. Maybe it'll be early today. walk around the helicopter, make sure the big parts are there, nothing's leaking. Shit, no partner. Okay, strap in the back. My partner Ray's in the front. Fred's flying, fabulous Freddy. So we launch out. It's a short flight, maybe, I don't know, 10-minute flight, for what we hear is a head laceration. Patient vital signs are stable, weight look oriented. Head laceration. You've got to be kidding me. Come on, I'm like vacation mode now. So we land, get to the ambulance. I go in the back. Ray goes in the side. He's over the head. Go in there. Hey guys, how are you? Walk up, look at the patient. He's wide awake. Got this big bandage on his head. Looked like a turban. Massive. He's on a backboard. C-collar. So I look at him. I lean over him. I grab his wrist. I touch his radial arteries. What I do for every patient. We'll talk about that in a different module. I look him in the eyes. I'm Erik, one of the nurses, talking to him on his left side, because that's where I'm closest to, and trying to get any response. He just keeps saying, what? I'm like, okay, we're going to be going to the hospital. We're going to strap you in we're going to be buckled in really tightly. We're going to get you in a helicopter. We're going to go. If there's any problems, we'll get you unbuckled and out. I promise you it'll keep you safe. And as I'm talking to him, Ray is unwrapping this massive bandage because we want to see what this huge laceration is that we're flying, my vacation time, to Tampa General. So we take this turbine off, and I'm in the middle of talking to this gentleman. This is real time, looking him in the eyes. He's looking at me, a younger guy, probably in his mid-30s. And as Ray takes off the last piece of the bandage, envision looking at someone in the eyes. This bandage comes off, and just above his eyebrows, all the way across, it's nothing but skull. So this guy was working in a machine shop, had a long ponytail, whipped it around. His ponytail got caught in a high RPM drill, and it ripped the scalp off, like that. And all the arteries and vessels spasm, so there's no bleeding. But it ripped it, if you can envision, above his eyebrows, along the left side. It took off his left ear, down the back, underneath his hairline, all the way around, over his right ear, and across top was nothing but crisp white skull. And I tried my best not to have my jaw drop talking to this man, who looks very calm, by the way, he's in no pain. And I'm like, I gotta keep a straight face with this. It was amazing to me. It was like a half inch between where his glabella was, where that soft tissue was, down to this crisp white skull. I can see the sutures, I can see everything. So we wrap it back up. I look at Ray with the same look he gives me, eyes wide open. Yeah, okay, yeah, this is all right. So wrap him back up, get outside the ambulance. We're wheeling over to the helicopter, and one of the medics gives me a yellow McDonald's red cap water cooler. Very heavy. What's this? Oh, that's a scalp. The co-workers decided to put it on some ice for you. I'm like, oh, that was nice. So we're going up to the helicopter. I can't hold the patient's stretcher, so I give it to a pilot. He's like, what's this? I'm like, it's a scalp. He's like, don't worry about it, Freddie. You got it. Get the guy in the helicopter. We fly to TGH. Come over. Vital sign stable, everything. So I open up this McDonald's cooler, and his co-workers were nice enough to put it in ice, but they didn't put it in a bag in ice. They just threw it in a bucket of ice, and it's hot out. And as I'm pulling out the scalp with skin and this very long, now no longer in a ponytail, this rat nest of hair, it's just riddled with ice chips. So I'm an hour into what's supposed to be my vacation, sitting on the floor at Tampa General, their old ER, pulling out clumps of ice one by one out of this scalp, this very long hair, going, started my vacation. It's going to be awesome. So it did wind up getting reimplanted. Again, the head's very vascular. It reimplanted well. So the man's walking around and his scalp is intact. But I was amazed. I learned something that day of how much protection that scalp offers before it even touches the skull. So yeah, Tanisha, what do you imagine my mouth looked like? So yeah, hung wide open. So anyway, there's another fun story for you. I got plenty of them through this course. So the other thing we have is those nice meningeal layers and that CSF to help with that brain tissue, which brings us into our traumatic brain injuries. So we have primary and secondary injuries. Our primary brain injury, that's the time of the injury. So it results from the external force. Somebody hit me with a bat in the head, that's the primary injury. And categorically, it can be focal, just confined to one area. Could be diffuse, damage throughout the entire brain or many parts of the brain. Can be microscopic, with diffuse axonal injury. You can get areas that may not be seen until necrosis sets in. Open, that means that there's a conduit, there's a fracture, again, that exposes the matters to exogenous forces which can lead to infection. And the damage may occur to underlying vessels, so it can get secondary bleeding, dural sinuses, brain and cranial nerve involvement, or can be closed. And closed primary traumatic brain injuries, that skull remains intact and the damage is done to the tissue. And that's the problem because we result in increased intracranial pressures elevated. And as we know by now, it's not good. Severity really spans the spectrum, mild, moderate, severe, and we initially use our Glasgow Coma score to figure out what that debilitating TBI is. So that's a great initial indicator. A secondary brain injury is a little bit different. It has nothing to do with trauma. Secondary brain injury is your body's physiologic response to the injury. Remember, if I twist my ankle, the injuries, or better yet, I get hit on the ankle with a brick, that's the injury. But my body's going to respond in kind. It's going to increase capillary permeability, it's going to send white cells and macrophages, and it swells. That's secondary brain injury. You get damage done, and it's due to hypotension or hypoxia, intracranial hypertension, cerebral edema. Your body is responding to that initial insult. So you may get a MAP less than 70, PaO2 less than 80. You get increased intracranial pressures, and this can lead to brain herniations. So your body's doing what it should do. It's sending all this stuff to swell the area, which causes secondary problems. Primary injury is the insult, secondary is the response to the insult. There's one type of injury called a coup, contra coup. It's kind of cool. So a coup injury is if I slam my head on a table, and again, that brain's going to go forward, it's going to hit the cranial vault, and that's where the injury is, the front of the head. But remember, that brain is in a fluid capacity. So again, just because my head stops, is that brain going to stop? No, it's going to go back and forth. So as the brain goes back, it's going to hit the back of the skull. And this is a GIF that shows that. It hits, boom, front, back. You can see how that brain moves within that cranial vault, causing a coup, contra coup, contra coup. Different injuries. So when somebody has an isolatory external trauma, they have two foci of injury inside that brain. The forces that we come in contact with, external energy, we have acceleration forces. You know, sudden rapid onset of motion, a blow to the head, hit to the back of the head, whatever, that brain, that cranial vault goes backwards, but the brain stays intact, so it smacks against the front of the head and that front of that cranial vault. Deceleration forces, again, the energy is halted, so the brain doesn't. The cranial vault stops, but that brain goes forward and back and forward and back. So just remember that these forces are going to cause injuries to the brain, even if we don't hit anything. You could also have tension, compression, bending, shearing, torsion. It's usually a combination of these forces when we talk about traumatic brain injuries. Most common causes, blows to the head, falls, particularly in our elderly population. Rapid acceleration, deceleration. Again, there doesn't have to be an impact of the head, but remember, if the whole body stops quickly, the brain is going to move around. I think that GIF shows it very, very, GIF or GIF? It's GIF, right? If I mispronounce it, let me know. I'm going to sound old. Motor vehicle accidents, that's a really good cause. Sports, again, we get a lot of head-to-head contact. That's a reason why helmets are becoming more and more popular in other sports that they never were, like girls lacrosse, for example. Assaults, projectiles, penetrating like bullets and knives, head impacts, blood trauma, hammers, bats, whatever, and concussive forces. You know, blast injuries, there's primary, secondary, tertiary, and quaternary forces with a blast injury, but that primary injury is the blast. That's the concussive force. It's a shock wave, and it comes and it hits the body. It can cause tympanic membrane ruptures, pneumothoraces, broken bones, globe ruptures of the eyes, and it joggles the brain around in there, so that can cause a concussive force. Types of brain injuries we come into contact with, concussion. That's what we call a mild traumatic brain injury. It's a mild diffuse area of injury. It's often called a mild traumatic brain injury. It's blunt trauma to the head, neck, or different parts of the body, but forces are transmitted to the brain, and you don't see anything on a CT. We see this a lot in youth sports now. That's actually made a huge thing with youth sports, with concussion protocols, because we know not only does that initial concussion that can last for a long, long time and cause even learning disabilities, but we know if we get them too soon, and they get a secondary concussion, they get secondary concussion syndrome, that can exacerbate that significantly. Contusions, just bruising on there. Diffuse axonal injury is a shearing force. So think of that brain in there, like that little GIF, but what happens if it's so abrupt that it shears off all the axons? And now there's no neuronal transmission. You don't see anything on a CAT scan. You just see brain and tissue. But you get a PET scan, and you're really going to see this complete disruption rotation, acceleration, deceleration injuries. It's devastating because there's nothing we can do. We can't put our finger on it to fix it. We can't give a medication to fix it. Intracranial hemorrhages, they can be epidurals, which is arterial in nature, subdurals, which are venous in nature, or intracerebral, they're inside the brain. Intraparenchymal hemorrhages and the parenchyma. So when we look at the thing called an epidural hematoma, we know that it's arterial in nature. It's a collection of blood that forms between the dura mater and the skull. And up on this picture here, it's right here. I call them the lemons. They're the lemons on a CAT scan. If it looks like a lemon, it's an epidural. The bananas are subdural. See, it looks like a banana. You want to hunt smart when you're looking at a CAT scan? There you go. 90% of those are associated with fractures of the temporal artery, the parietal bones, and you lacerate the middle meningeal artery. It's very rare. However, the blood accumulates and an expanding hematoma forms, and it causes compression of the underlying brain tissue. Space-occupying lesion. Rapid rise in intracranial pressures, it decreases cerebral blood flow, and you get secondary brain injury on that. Your body responds. It requires immediate surgical intervention. The cause is most commonly motor vehicles, falls, sports. There was one, Bob Saget, they thought had an epidural hematoma. They're pretty much sure that's what the cause of his was. There was a girl years ago at a hockey game who took a puck to the side of the head, and she went out for a half a second, came back, was fine. Denied therapy, father denied any treatment. They went home, put her to bed, and she never woke up again. Which brings us into our classic symptomatology of an epidural hematoma. They have this transient loss of consciousness, followed by a lucid period. They're wide awake. I'm fine, nothing wrong. It can last minutes to hours. And then rapid deterioration in neurologic status. And sadly, a lot of them rapidly deteriorate when they go to bed. And nobody's there to pick up on the signs and symptoms. They may be nauseated, vomiting, contralateral hemiparesis, hemiplegia, abnormal posturing. Remember on the GCS we spoke about flexion and extension, decorticate and decerebrate. Extension is the more ominous because the brainstem is herniating and has very, very poor outcomes. Ipsilateral, undilated, fixed, and dilated pupil may occur. So remember we spoke about pupils and how, if you have a stroke on one side of the brain, the other side of the body is affected. Not so much when you have an uncal herniation, because when we talked about that optic chiasm and decussation, it happens below cranial nerve number 3. So that innervates the pupils. So what happens is the affected side, that pupil becomes blown and dilated because that's herniating through that foramen magnum. The other one's a subdural. Now, subdural is a collection of blood, and it forms beneath the dura, below dura, and it's following an impact, acceleration, deceleration, but it's venous. So it's a bridging vein that winds up getting disrupted from the direct injury. It's much more common than epidurals. And there's 2 types. There's an acute, which usually within 72 hours they start to get symptomatology. And it's usually from a fall, an assault, or some sort of motor vehicle accident. They have nausea, vomiting, headache, changes in loss of level of consciousness. Again, ipsilateral, dilated, same side, dilated pupil, maybe non-reactive, unilateral weakness, hemiparesis. Then there's chronic ones. This can happen from a minor injury in adult patients, particularly from any anticoagulant use, but it develops over time, sometimes as long as weeks after the injury. They get confusion, headache, loss of memory, altered reasoning, kind of a lot of dementia-type symptoms. So that can be confused for. Remember, differential diagnoses for these patients. Just because coming in for the few weeks of this, don't immediately think dementia or Alzheimer's. Uncover the underlying organic cause. Oh, H&P. Well, yeah, I did fall 2 weeks ago, but I would have been hurt by then. Subarachnoid bleed we went over, and that is a stroke state. That's a hemorrhagic stroke, although it is bleeding within that space, but it's in the subarachnoid area. Herniation that we touched upon, again, it's a shifting of that brain tissue and displacement into another compartment. And it's either bleeding or edema, something that's occupying space. And it shifts, compresses, tears vasculature, and a decreasing perfusion. There's 2 types. There's the uncal herniation. That's the shift of the midbrain from one side to the other. So you get the dilated pupil on the affected side. And that's seen kind of quickly, usually before mentation changes. It puts pressure on the cranial nerve number 3. Again, we talked about that. That's above that level of decussation. There's no initial changes in LSC, but immediately it'll start to degrade. Now, the central or transtentorial herniation, that's the cerebral hemisphere is pushed down through the tentorial notch, and that compresses the brainstem, and that's what starts to squeeze through that foramen magnum, both sides. This is where they get that Cushing's triad. Respirations, they get dilated pupil, or non-reactive pupils, bilaterally, hemodynamic instability. They get that systolic hypertension, widening pulse pressure, bradycardia, Babinski reflexes bilaterally. Here's a CT which shows an umbilical herniation. Again, it's all shifting to one side. That should be right in the center. And then transtentorally, you can see here, this is an MRI, but you see it, here's the foramen magnum. They're both starting to shift. The left side is going much more than the right side at this point. And I told you last week about breathing patterns and how we can kind of pick up on what's underlying the patient's condition just by looking at the respiratory patterns. Kussmaul respirations is a classic one. We understand that someone has these deep rapid respirations. They're probably diabetic ketoacidosis. They're trying to blow off all that carbon dioxide to compensate for the acidotic state. But when we look at neurologic breathing, like Cheyne-Stokes, increased intracranial pressures, and then they go apneic for a period of time, and then it starts that sequence all over again. So we can look at different types of respiratory patterns, and it gives us a little scratch into the window of what's going on pathologically. It's a great assessment tool. We talked about intracranial pressures last week. We're going to revisit them again. Again, with patients with increased intracranial pressures, we can monitor them. That's whether it's a TBI, CVA, hemorrhages, tumors, infection, it doesn't matter. We can monitor intracranial pressures. We know that decreasing intracranial pressure, it prevents further brain damage. Normal between 5 and 10 millimeters of mercury. We want to maintain it below 20, but we can assess for signs of increased intracranial pressure. Again, this is all revisiting this. Neurologic assessments routinely, and we see level of consciousness changes, hypertension, widening pulse pressures, bradycardia, headache, vomiting, papilledema, changes in respiration, and that Cushing's triad indicative of herniation, irregular respirations, bradycardia, widening pulse pressure. Interventions that we kind of touched upon last week, medically, we want to lower the pressure. We can decrease volume. Osmotic diuretics like mannitol, loop diuretics like Lasix, hypertonic saline. Again, we give that intravascularly. It pulls the fluid out of the cells and it decreases the swelling within the brain. We can reduce cerebral spinal fluid. We can do a ventriculostomy. We can drill into the lateral ventricles. We can actually suck out via gravity the extra CSF that's in there. We can give them sedatives like propofol. It's a continuous drip that we give them, and it reduces intracranial pressures as much as 15 millimeters of mercury. Hyperventilation is no longer recommended. We spoke about that. We know that hyperventilation causes vasoconstriction, but it also reduces cerebral blood flow, causes alkalosis, and it has a rebound effect where it then floods the cerebral perfusion pressures and increases pressure. We want to avoid PEEP, which is positive end expiratory pressure. We're going to talk a lot about PEEP with ARDS and some of the respiratory issues and sepsis. PEEP is really, really beneficial, but PEEP increases intrathoracic pressure. Intrathoracic pressure prevents optimal jugular venous outflow, so it increases intracranial pressure. So we avoid that in these patients. And we want to avoid lumbar punctures. That's a huge contraindication with patients with elevated ICP. Again, I highlighted the important area here that it may lead to either transtentorial or umbilical herniation and acute neurologic deterioration. If you know you have elevated ICP, we're not doing a lumbar puncture on these patients. Medically interventions, we can control the pH. We know that acidosis causes dilation and alkalosis causes constriction, so we can control their pH. Again, on a ventilator, it's relatively easy for us to do. Preventing hypoxemia and hypotension, we know that one bout of either of those significantly increases the mortality and morbidity of patients. Positioning, again, nursing-wise, keep the head of the bed 30 degrees, keep the head neutral alignment, roll the patient as a unit. We don't want to flex their hip. Have the patient exhale during repositioning. It opens up the glottis, it decreases intrathoracic pressures, prevent coughing, sneezing, and straining. Again, we can give medications to treat most of that. Diet, they need protein. Although the meningitis patient, we want to avoid protein. The traumatic brain injury patient with ICP, they need protein. Low protein decreases serum oncotic pressure. So what that's going to do is force fluid into the cells. When we increase the oncotic pressure, again, we maintain that homeostasis between the intravascular volume and intracellular volume, and then it allows us to manipulate to pull fluid from the cells. We don't want to strain them for agitation purposes, and treat fevers because that's a hypermetabolic state. Interventions again, assessment, we focus on the neuroassessment. Pupils, again, in the first 24 hours, that's the eyes into the soul. Are one affected? Are both affected? What's the size? Are they reactive to light and accommodation? Motor assessments. Is there any hemiplegias? Is there weakness? Is it unilateral, bilateral? Are there Babinski reflexes? If anyone doesn't know what a Babinski reflex is if I take a reflex hammer, the sharp end of the bottom metal, or a pen, or my thumbnail, and I run it up the plantar aspect, the bottom of the foot, in an arc motion from the heel up above, underneath the toes. What should happen is all the toes should flare out. What happens in a Babinski is the toes curl and the big toe flares. Normal in infants, abnormal in adults. Vital signs, we watch for trends. Hey, the systolic blood pressure keeps going up. The diastolic keeps going down. The heart rate keeps going down. Getting Cushing's triad. Look at their oxygenation to avoid hypoxia. Look at their ICP levels if we're actively monitoring it. EKG labs and ABGs. And when we discharge the patient, the goal for traumatic brain injury is just to have them actively participate in the rehab process. It's really, really huge. That's really the goal. When we talk about intracranial pressure monitoring, there's a couple of different types. There's interparenchymal probes, epidural probes, intraventricular catheter, and subarachnoid screws. I got a video, because this is actually done at the bedside. It can be done in an emergency department, it can be done at the bedside of your floor. This isn't done in the operating theater, but it's pretty, I guess, impressive, for lack of a better term, how they do it. So I want to quick show you a snippet video.
And clean water using the washcloth or brush. Dry the skin with a hand towel and shave as necessary. Identify the anatomical landmarks and mark the incision site. Generally, ICP monitors are inserted on the side of the non-dominant hemisphere, which is usually the right side. The incision is made along the mid-pupillary line, 3 cm lateral to the midline to avoid the sagittal sinus, approximately 11 cm posterior to the nasium, and at least 1 cm anterior to the coronal suture to avoid the motor strip. Put on a face shield. Wash and dead. Larger sterile drapes may also be used, but follow local guidelines. Raise a bleb with local anaesthetic. Make a short 5mm linear stab incision. Use of a retractor is usually unnecessary. Ask an assistant to secure the patient's head. Place the drill perpendicular to the skull and turn the handle clockwise. Do not lean on the drill. You will usually be able to feel the drill bit penetrate the hard outer cortex, the soft central medulla, and the hard inner cortex. Place the bolt in position perpendicular to the skull and turn it clockwise, usually 9 half turns until it is secure. Loosen the cap of the bolt by turning the adapter counterclockwise and make a puncture in the dura using the dural puncture stellette. Cerebral spinal fluid may be visible at this point. Switch on the ICP transducer. You may place a purse string suture which can aid in wound closure after the bolt is removed.
So you get the idea. And this is a way for us to monitor the intracerebral pressures, and also a way that we can drain extra CSF off the brain. Comically, at one point in our career here, they wanted us to do these in flight. We decided that's probably not a good idea. So, all right, next thing we'll talk about is, we're almost at the end, 2 slides, brain death. It's determined a brain death occurs by established criteria. It's nothing willy-nilly. A neurologist involved, critical care intensivists are involved. They have to be comatose. Again, so we observe them for a period of time to determine that client will not recover. They have to have normal or near normal core body temperature and a normal systolic blood pressure greater than or equal to 100 millimeters of mercury, and at least 1 neurologic exam, sometimes a couple per state. So again, it's something that's not taken lightly. We don't just harvest organs. It's a process. Last question is, what can we check to determine if leaking fluid from the ears is CSF? Halo test, interparenchymal probe, glucose test, and the last one is EEG. What do you think? What things can we check to see if it's CSF? Halo, glucose, yeah, it's a SATA. 1 and 3. You're right. Absolutely. So halo test and glucose test. So it's not too bad. And ladies and gentlemen, week 2 is in the books. So let me stop sharing this. Let me start this. Not too bad, huh? What do you think this week? I mean, it's weird because we're back virtual, which is boo. However, try to liven it up. I like the videos. I like to give different types of learning. But hopefully I kept your attention for the most part. I mean, if you snooze, at least you kept it nice and didn't make it loud. Any questions on Module 2? That was good. All right. Yeah, it's not bad. So we're done early. I knew we would be a little bit early, and I didn't think there'd be any objections to that unless you want me to keep you here longer, but I doubt that. Too fast for you? Everyone okay with the pace that it goes at?
No, I just like the little bunny because it's almost Easter, and yeah, I'm sorry. I was just like, oh, I see a little bunny. Like, okay, no, you're not too fast. You're great.
That's
Your face
okay.
is perfect. Thank you. Yeah.